Hello, and thank you for joining our podcast, Non-Small Cell Lung Cancer Morning Commute, the newly diagnosed patient. Morning Commute is developed in collaboration with At Point of Care and Projects and Knowledge and is part of a continuing medical education series. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals and Sanofi Genzyme. Information about the faculty and disclosures can be found at morningcommutepodcast.com/NSCLC1. You can use this link to receive your credit and evaluate this program. This URL can be accessed in the episode notes. You can also find the complete three-part series by visiting morningcommutepodcast.com/NSCLC. Joining us today is Dr. Nair Rizvi, who is the Price Family Professor of Medicine in the Division of Hematology Oncology at Columbia University Irving Medical Center in New York City, and Dr. Sarah Goldberg, who is an Associate Professor of Medical Oncology at the Yale Cancer Center, Yale School of Medicine in New Haven. In this episode, Drs. Rizvi and Goldberg discuss the current standards of care regarding patient workup, diagnosis, as well as PD-L1 expression and the emerging immunotherapy biomarkers in treatment selection for non-small cell lung cancer. I am your host, Candace Hoffman, Managing Editor of Morning Commute. Dr. Rizvi will begin our discussion.
Welcome to our first podcast on non-small cell lung cancer. It's entitled "A New Patient Walks into the Clinic," or these days, a new patient is being seen on a Zoom call. Sarah, do you want to talk about your experience with new visits in person versus Zoom these days and how that's been going?
Yeah, hi Nair. That's a really interesting point. Most of our new patients are still coming in person, but we are seeing some people through telemedicine. It's a different way of meeting someone for the first time, especially. It can be challenging, but I think it is good during these unusual and difficult times that it's better to have some distance in some cases. So we are doing some telemedicine, virtual new patient visits. Nothing like being in person, though.
No, it's true. Well, hopefully with the COVID vaccine emerging for more and more of our population, we'll have 2021 be a better year. So let's jump into this. I think we have a lot to talk about when a patient does walk into our clinic. There's certainly a lot of work that has been done already by the time a patient comes to the medical oncologist, and they've likely seen their primary care pulmonologist or possibly a thoracic surgeon. So many of the tests have been ordered. Sarah, do you want to just talk to some of the initial workup that you feel is required when you see the patient in the clinic?
Sure. So you're right. Many times when we see the patient, it's after a lot of testing has been done. Sometimes medical oncologists are the first stop for patients who have a suspected diagnosis of lung cancer. There's many newer tests that are really important to obtain, but still the basics are so critical, right? By making sure we know the diagnosis, the histologic diagnosis, as well as the stage. And so that's typically the first thing that I think about is, what is the stage of this patient? Do they have advanced disease, metastatic disease, or is it an early stage where we could think about a curative strategy of treatment? And so in terms of that, typically we're thinking about imaging. I think CAT scans are usually, maybe x-rays are usually the first thing that patients get, but then typically CAT scans we have that information typically before someone comes to us in medical oncology. I think a PET scan is still important for most patients, maybe with the exception of very early stage cancers, although in medical oncology, we don't tend to see those initially anyway. But PET scans, I think, are still very important. They can give us information about the stage, about the extent of metastatic disease, and then brain imaging. So I almost always get brain imaging on my patients with, definitely with stage 4 disease, but even stage 2 and 3, I think it's important to get brain imaging because brain metastases are so common in lung cancer. And then in terms of the histology, I think, again, a lot of times patients have biopsies before they come to us. If they don't have a biopsy, I'm always thinking about, where can we get a biopsy from that can give me information on the stage? So if there's a concern for a distant site of disease, especially if it's it appears to be limited disease, with one or just a few metastases, I'm always going to want to try to get a biopsy from those sites. And then also making sure I'm getting enough tissue. So, SNAs are something that I rarely send patients for anymore because we do want information from that biopsy beyond what the histology is. So yes, histology still is really important. If I have kind of some sort of vague report from my pathologist, I'll go back to them and say, well, what is the specific histology? Can we understand that? Sometimes that's not possible, but sometimes additional markers may be helpful. And then, I think there's more nuanced details about the biopsy and what we want to get from that based on the stage. So maybe before we get into that, is there anything else that we wanted to talk about with workup and staging? And then maybe we could talk more about the molecular testing.
Yeah, I can sort of talk to a little about molecular testing next. No, I think that's great. For this discussion, I think we'll mostly be talking about going forward, talking about advanced stage patients where surgery is not going to be an option for patients in terms of determining what the right systemic treatment is. And certainly histology in terms of differentiating adenocarcinoma versus squamous versus small cell, I think is obviously very important. Within adenocarcinoma, it really is incredibly important to have the molecular testing results. And sometimes when we see people that have had biopsies elsewhere, it can be challenging to track down their molecular results. But I think it's really important not to start treatment until you know what the molecular status is. And certainly we have a number of mutations or gene rearrangements that we look for to make sure they don't have a druggable target. The most common ones being EGFR mutations and ALK rearrangements where we have FDA-approved therapies. Targeted therapy really trumps chemotherapy or immunotherapy should be the first treatment of choice. Do you want to talk a little bit about your approach at Yale in terms of your molecular testing that you do there?
Sure. So it's actually an evolving story about what we're doing here at Yale. So as you mentioned, EGFR and ALK are two of the most common actionable mutations or alterations. But it seems like every other month we're finding out another alteration that we have actually a really effective drug for. Even in the last year, we've had several new targeted therapies approved for different alterations. So, our approach had been to get a fairly limited panel that included EGFR and BRAF, which I think are two of the most important genes to test because they can be mutated and they have targeted therapies associated with them. And then we also were getting ALK and ROS1 by FISH. But again, because there's now so many more alterations that are important to know, even for first-line therapy, we've kind of decided to broaden our panel. So we were doing this more limited testing because it came back fairly quickly. And then if that was negative, we were kind of almost reflexing it to a larger panel. But because these are so important, and actually, again, it can be used for first-line treatment, in many cases, we're now starting out with a larger panel. And I think that that's really become more common at many places to start out with a very broad panel. And so I don't consider my workup complete until I have information on EGFR, ALK, and ROS. Those are kind of the three ones that we've known about for a while, but now also BRAF, MET exon 14 skipping mutations, RET fusions, and also NTRK. So some of those get to be pretty rare. NTRK is exceedingly rare, but it happens, and it really is important to have that information. So I think all of those are. Nair, did I forget any, by the way, before I move on? I think I got them all.
You got them all.
So I think those are all so important to test, I think, for a patient with metastatic adenocarcinoma. Ideally, before you start treatment, it's not always possible. There are some cases that patients are really sick and need to be treated before you get all of that information. But I would say the vast majority of my patients that I see, I'm able to get that testing done so I can kind of choose the best treatment for them up front. The other thing that we're doing a lot more these days is using liquid biopsies, so circulating tumor DNA testing to get that molecular analysis. There are patients, just as you said, where they come in and they had a biopsy at another hospital, and then they come to see me and they're pretty sick, and I know that it will take, even just a couple extra days to get that tissue here, or for whatever reason, I think, I'm worried there's a limited sample, or the testing hasn't gotten even started yet for whatever reason. And that's when I'll think about sending blood for circulating tumor DNA. because I can get that information typically back even faster than some of the tissue-based testing. And it can be a good source of information that you can get back quickly. If you find something on ctDNA analysis, I think that is now data that shows that that's just as good as getting tissue testing and potentially even more comprehensive. So I will often get that these days as well.
That's great. Also clinically, I mean, it's not an absolute guide, but you're more likely to see, some of these druggable targets in patients who are never smoked or minimally smoked versus those patients who do have a prior smoking history. And, about a quarter of our patients with lung cancer, never smoke. And so we may do even more extensive genetic testing, DNA and RNA-based testing on some of these patients to really try to determine whether they have an oncogenic driver. And certainly, if a patient tests negative for a druggable target, I think the other part, which is really important in terms of thinking about therapy is PD-L1 expression. This is a pretty fast immunohistochemical stain that's done pretty routinely at really everywhere. And determining PD-L1 expression will really give us a clue in terms of the likelihood of immune checkpoint blockade immunotherapy in terms of likelihood of working. It's certainly not an absolute biomarker, but we now have drugs approved first line based on level of PD-L1 expression. The threshold that's typically being used now is a 50% threshold. So about a third of our patients that we see with lung cancer will have positive PD-L1 expression. So Sarah, do you want to talk about first-line therapy a little bit in terms of immunotherapy options to focus on to start with, in terms of what are our options in terms of immunotherapy first line?
Sure. So I agree with you. I think PD-L1 expression testing is really important. I try to get it for all my patients with advanced disease. And the reason is that it really helps me figure out the best first-line treatment for patients. As you said, the cutoff of 50% has been shown to be an important one for predicting for benefit from single agent immune therapy. So for patients who have that high expression, more than 50% PD-L1 expression, I would be very happy for most of them to consider a single agent immune therapy, PD-1 or PD-L1 inhibitor. There are some patients where I might be more hesitant that they may need additional therapy besides just a single agent, but I think for most patients, the PD-L1 really helps to define the group of patients who has a good chance of benefit from even just single agent immune therapies. Pembrolizumab was the first drug that we knew about as a single agent to have benefit in the first line setting in the high PD-L1 patients. That's the drug that I've been using for some time. I think that's probably pretty common among people who treat patients with lung cancer. But now we also have other drugs that are showing really significant promise, and some of which have been approved now. So atezolizumab also as a single agent in the high PD-L1 expressors is also approved and an option for patients. And then there's some other drugs that are kind of now, so we're starting to see some really exciting data and at some point may be approved. And cemiplimab, I think, is a good example of that, where as a single agent compared to chemotherapy, similar to these other trials, it also shows really good evidence of benefit with a survival advantage compared to chemotherapy. So that one's not approved yet, but I think it very well could be based on the very positive data. And so I think that high PD-L1 expression is still really important to detect. So, so I hear sometimes people saying, well, why do we even need PD-L1 expression? Because we could just give everybody chemo and immunotherapy combination. But I think it's really nice to be able to treat patients with single agent drugs or single agent regimens when we're able to. And it's those high expressors where I typically feel comfortable with that. For the lower expressors, the 1 to 49% patients, PD-L1 patients, I think you still could consider single agent pembro, but typically I usually think about combinations for those patients, usually with chemotherapy and immune therapy, although Ipi/Nivo is now also an option there. And then same for the PD-L1 negative patients. I don't think most people would consider single agent for those patients, but combinations are important for those patients in immune therapy plus either chemotherapy or even considering again Ipi/Nivo for those patients. Despite lack of approval in that population, I think that still could be a consideration based on the promising data there. So I think we have a lot of options, and the PD-L1 really helps to guide that that decision, which again is why I think it's so important to get in the initial workup.
Yeah, I think that, the PD-L1, is first, number one, make sure they don't have a targeted therapy option. And number two, what the PD-L1 is, and deciding whether to give PD-1 or PD-L1 monotherapy versus chemo combination. And there's a number of chemotherapy combinations now with pembrolizumab, with atezolizumab, and bevacizumab, and chemotherapy. And so I think, but in terms of just the broad picture, deciding monotherapy versus chemo combinations, I think that PD-L1 does help you. I have to say there's definitely some patients that are PD-L1 more than 50%, but I will give chemotherapy and PD-1 too as well. It's really kind of, as you said, weighing what, how much disease burden they have, how symptomatic they are. If you're, not sure they're going to be able to wait and see if the immunotherapy is effective, you may want to use a chemotherapy and immunotherapy combination up front. But by and large, the more than 50% will get pembro or atezolizumab. I think the cemiplimab approval, I think, is another drug which will be likely approved later this year. That's very active in the first line setting. Do you want to talk a little bit about whether you give every 3-week pembro, or whether you like an every 6-week regimen, which is also an option for our patients, where you get double the dose, but you get it less often? Maybe during COVID, this regimen got more interest, but I think for some patients that are traveling a great distance, it can be useful. Your thoughts on that?
Remember to visit morningcommutepodcast.com/NSCLC1 to receive your credit and evaluate this program. COVID-19 has impacted clinical practice around the world. Drs. Rizvi and Goldberg discuss how immunotherapy dosing has been impacted by the pandemic. Let's rejoin the discussion.
Yeah, I agree. I was going to say the same thing, that I was using the every 3-week regimen that the trials used and what I was accustomed to doing. And then during COVID, when the COVID pandemic started, we all talked about ways that we could limit potential exposures of patients to the clinic, and how we can bring people in less often but still do it safely. And that was one of the big strategies that we used, was changing to every 6 weeks pembro. Then when things quieted down over the summer here in Connecticut, we kind of just still stuck. I think the data looks good comparing the two doses, I think, and regimens, and I think it's reasonable to do the every 6 weeks treatment. So that's now typically what I'm doing for most patients. Can I ask you a question, Nair? Are you getting PD-L1 expression on earlier stage patients? Are you getting this on stage 3?
We have been getting we tend to get it reflexively on early stage and stage 3 patients. So we do get a PD-L1 score and a molecular results on really everyone that we see.
I was going to ask, are you getting molecular testing on your on your squamous patients or small cell patients, or is it just the adeno?
Yeah, so I think that's a good question in terms of squamous, whether we do molecular testing. We haven't been, unless they're never smokers or have a minimal smoking history, and then we'll get it in that case where they may have an actionable mutation or rearrangement. Certainly with clinical trials that we're doing, we're getting it on our squamous, but in terms of standard of care, not routine.
Yeah, I agree. We get it on people who have a light or never smoking history, but I agree. Otherwise, it's not really probably necessary to do in most patients.
So I think PD-L1 is a good guide. I think we all have been looking for the last number of years for better biomarkers. Certainly tumor mutational burden has been researched quite a bit in terms of immune checkpoint blockade use. Basically, tumor mutational burden is really counting all the expressed mutations that a patient has, and sort of accumulation of genetic damage that's present within the tumor. Initially, we were doing this off of whole exome sequencing, but now, with certain formulas, you can determine it off more targeted gene panels, ranging from 300 to 500 genes that are routinely used at many commercial laboratories. There is certainly data that that patients with higher tumor mutational burden are more likely to respond to immune checkpoint blockade, but there's also some conflicting data in that space as well. So, Sarah, you can tell me, is tumor mutational burden useful or useless? And do you use it? Is it worth getting?
Yeah, so there is absolutely a signal there in many studies, including yours, that it can be useful in predicting who will benefit. But I don't know that we're there yet to use it as part of standard of care. I think it does predict for benefit, but I don't know that it clearly helps us decide which patients to treat and how to treat them well enough to use it clinically. I think now first line patients are all getting immune therapy regardless of PD-L1 expression. It just depends on if you use it as a single agent or in combination. And so if something like tumor mutation burden could help us decide that would, I think, be potentially useful. But I don't think we're there yet to be able to say that it should be part of the algorithm of how to select patients. Maybe one day. I think, it's still absolutely an ongoing area of research, and I think there may be something there, and there may be a way to use it, but I don't think it's ready yet to be used clinically, at least not in my practice.
Yeah, I think that's right. And we do tend to get it for our new patients, but we don't necessarily wait for the results. I mean, I think we want to get the T mutation data. I have had scenarios where, patient may have started on, monotherapy with PD-1 inhibitors, and I wasn't sure if they're responding or whether it's working, or if there was some pseudoprogression, and the patient had a high TMB, so we sort of persisted, and the patient did eventually respond. But sometimes it can take time for these therapies to work. And another therapy, I had a patient who was getting chemotherapy in pembro, and he was an elderly gentleman, and he was having a really rough time tolerating it, but he came back with an extremely high tumor mutation burden, so we actually dropped the chemotherapy earlier than we would have otherwise. So I think it can help shape your therapy, give you another piece of information, but it certainly wouldn't be the first thing on your decision tree in terms of using to make decisions.
Yeah, I think it can give you more confidence that you're on the right track on a treatment, but I don't know that you can use it as an initial predictor and use it for selection. So those are good examples of how it might push you a little bit one way or the other, or give you more confidence in what you're doing. But I think still, even though PD-L1 has so many challenges and flaws, it still is our best predictor in lung cancer, and it's different in other diseases, but in lung cancer, it definitely can predict for benefit. The challenge is that even the high PD-L1 expressors may not benefit, and the low ones may. In the early days of immune therapy, when we were using it beyond first line and using it in second line and beyond, I had a few patients I treated with single agent immune therapy who were PD-L1 0, and they did fantastically well for many years. So it's clearly not a perfect biomarker by any means, but I think that still is our best way to select patients.
And some of the trials will be giving treatment for 2 years and then stopping. Some of them will be continuing it indefinitely. So what do you do? I mean, are you a 2-year person, or are you a continue indefinitely person?
Oh, I'm a confused person. I think this area is really a tough one. Most of the trials, or many of the trials, all the pembro trials, as far as I know, were 2-year treatments. And then patients stopped after 2 years, even if they were continuing to respond. And so, the pembro trials look amazing in terms of the benefit. And so that gives you, I think, good reason to think, we could stop at 2 years because that's what the trials did. If you look more into the details of some of those trials, many patients continue to respond beyond 2 years despite stopping, but there are some who progress. The problem is we don't know for sure whether it's because they stopped or they would have progressed anyway. And then also we're starting to get data on whether retreatment is useful. And I think, again, we don't really know yet. I think in some cases, clearly when someone stops treatment and gets retreated, they benefit, and other times they don't. I think we know from some studies that 1 year is not enough. 2 years may be enough. Basically what I do, because it's still in my mind not a clear answer, is I discuss it with patients. I say we don't have enough information to know for sure. There's still a risk of toxicity, although it's fairly low after the 2-year mark. I've seen it personally where patients are doing great and then they run into severe toxicity beyond 2 years. And so I tend to lean towards stopping at 2 years, but if someone feels very strongly that they want to continue, despite not having great data on that, and they're doing great with no side effects, I might consider continuing on. But I'm looking forward to hopefully some more data in the future, because I'm not sure what really the best practice is for patients. What do you do?
It's sort of case by case. I mean, I've had a patient on ipilimumab and nivolumab for over 4 years now, and she's still has some measurable disease, but it's sort of stable, and some nodes sort of wax and wane, and she's continuing on. And other patients who've had a complete radiographic and metabolic response after 2 years, and I'll stop them. So I think the chemo and pembro, I think it's a little more clear cut where you just kind of keep going as long as you're tolerating it. But for the immunotherapy only, I think it's sort of, case by case, depending on the magnitude of response, how they're tolerating it, what they have measurable, and things like that. Great. Well, thank you, Sarah. It was a good discussion on, a new patient who walks into the clinic and how we manage them. And thank you for listening.
Thank you for joining us today. Remember to go to morningcommutepodcast.com/NSCLC1 to receive your credit and evaluate this program. If you have missed any of our episodes or would like to listen to them again, please visit morningcommutepodcast.com/NSCLC to find a listing of all 3 podcasts.